Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Servia.
Good evening, everyone. Welcome to this symposium today, Medscape Symposium. I'm very much looking forward to this evening, to the next 90 minutes, in which we will be discussing clinical integration of therapeutic innovations in glioma. On behalf of myself, my name is Matthias Preußer. I'm a medical oncologist based in Vienna, Austria, and my co-moderator, Dr. Manmeet Ahluwalia, who is the chief of medical oncology at the Miami Cancer Institute. We want to welcome you here. We have a great faculty today, which I would like to introduce to you. Next to myself and Dr. Ahluwalia, we have Dr. Nicolas Gonzalez Castro from his neuro-oncologist from the Center of Neuro-Oncology at the Dana-Farber Cancer Institute. And we're also very happy and grateful to have Jeremy Pivo here, who is a patient advocate and will also enlighten us about his perspective and story. The agenda for the next 90 minutes will be as follows. First, we will have a talk by Dr. Ahluwalia on shifting paradigms of IDH mutant glioma management, which will discuss the latest developments and future directions in the field. I guess we will be hearing something about new drugs in IDH mutant gliomas and how to integrate them in clinical workflows and what are the data behind there. Then we will hear about the use of IDH inhibitors in the management of IDH mutant gliomas. How do we integrate these new drugs in the everyday clinical setting by Dr. Gonzalez Castro. And then Jeremy Pivo will tell us about how it is to navigate a life with a glioma, and will share some of his experiences across different treatment approaches that he saw. And in the end, we will have some first a panel discussion, and I will invite you to ask your questions via the question and answer tools. We will be discussing some of the aspects and we will hear about, and in the end, we'll have some concluding remarks. With that, very much looking forward to the program. The first talk will be given by Dr. Manmeet Ahluwalia on shifting paradigms on IDH mutant gliomas. Thank you.
Thank you, Dr. Preußer, for the kind introduction, and welcome everyone to an evening of learning. Today, I've been tasked to talk about shifting paradigm of IDH mutant glioma management, latest developments and future directions. So we tend to see patients with IDH mutant glioma in our clinics, and we know that sadly that we do not have any curative therapy, although these patients tend to grow slowly. The intent is how do we keep them alive as long as possible with the best quality of life. And it always in brain tumors starts with the surgeons. So the first job of a neurosurgeon is to resect as much as of the tumor possible, but safely. So the dogma always has been maximal safe resection, because you don't want to operate on a patient and the patient has a new neurological deficit post-surgery, because we know performance status is extremely important in not only how long our patients live, but also very importantly, the quality of life that they have. And so traditionally, obviously, we've divided the WHO grade 2s into oligodendrogliomas when they have a 1p19 co-deletion or astrocytomas. And there are traditionally, and this was a definition used for the RTOG in 9802, which was a landmark trial, where low-risk patients were defined by those who had a gross total resection, had good performance status, were positive for 1p19q co-deletion, were younger than typically 40 years. And in those patients, where you could get that resection and they were less than 40 years, you could wait and watch. But when you needed treatment, traditionally the brain tumor management has been radiation, and the RTOG 9802 basically established that there was an additional role of adjuvant chemotherapy. And for that trial, the drugs that were used were a combination of procarbazine, lomustine, and vincristine, commonly called the PCV regimen. And there's been data to support some use of temozolomide, which was a newer generation alkylating agent that we have used in the clinic, which particularly was, as you know, was approved for glioblastoma. So just talking a little bit about IDH alterations. So it was basically found in glioma. It was a science paper in 2008, basically showcasing these mutations in the IDH1/2 pathway that lead to a production of oncometabolite 2-hydroxyglutarate, which does occur in multiple cancers. And we know there have been therapies that have been improved in AML, cholangiocarcinoma. This is also seen in chondrosarcomas and in diffuse gliomas. And essentially, if you take a look at this busy Krebs cycle that those who have gone to medical school, we would all try to memorize in our biochemistry curriculum, and then you forget as soon as you leave it, was that in a normal cell, the citrate gets converted into isocitrate, and that basically gets converted into alpha ketoglutarate. But when there is an IDH mutant cell, that alpha ketoglutarate with the mutant IDH1/2 actually gets converted into 2-hydroxyglutarate, which is basically an oncometabolite that leads to then epigenetic dysregulation and cellular proliferation. There's often an immunosuppressive tumor microenvironment, and I will talk about how we can tackle that in later slides. And so this is a busy slide again, but basically it gives you an overview of some of the early phase trials of IDH1/2 inhibitors in IDH mutant gliomas. And so ivosidenib basically was the first IDH1 inhibitor which was used, and then we've divided the information on this slide in patients who have a non-enhancing tumors and patients who have enhancing tumors, because we know that there is a dichotomy of how these tumors respond to these drugs. So in the first table, you'll see ivosidenib, vorasidenib, BAY 1436032, which is obviously these numbers that we give to drugs in early development. And then we have safusidenib. And you can see the response rates in single digits, right? Ranging from anywhere from 4% to 8 to 9%. And that has been our challenge in gliomas, right? Unlike other cancers where we have new targeted drugs and we are seeing impressive response rates, gliomas tend to be highly infiltrating tumors, and it's very difficult to cause tumor shrinkages in this. So most of the times we have seen, even when we use the cytotoxic agents, the response rates have been typically around 5%, and that's been our take home for most of the time. And then when we saw the outcomes of these drugs in enhancing tumors, here you can see response rates even less gratifying, going from like 0 to 11%, and progression-free survival basically is almost like time to the next scan or maybe 2 scans. And that's also been story of our lives in patients with recurrent disease. So just going into a little bit more depth, vorasidenib was basically an oral potent reversible brain penetrant dual inhibitor of both IDH1 and 2. So this drug was really designed with an intent to work in gliomas, and it was specifically made brain penetrant. And here you can see very impressive IC50s of less than 1 nanomolar in IDH1 R132H alteration, which is the most common kind of IDH alteration we see in around 90% of our patients or so. And what also is interesting in the orthotopic glioma models, we basically was able to show that this drug caused this slowed down growth inhibition, and brain penetration was seen with a brain plasma ratio of 1.33. That means there was more selective drug in the brain compared to the plasma. So temozolomide, which is a drug that we have commonly used in patients with brain tumors, that ratio is actually 0.2. So this is, a drug which was specifically designed with brain tumors in mind. And here again, the pictures you can see in 2 columns. One is the waterfall plots, and basically if bars are going higher, that means tumors are growing. And as you know, we have defined an increase of 25% as progressive disease, and a decrease of 50% is a partial response, and complete disappearance is complete response. And here you can see those patients who had enhancing tumors, they were more likely to increase in size as consistent with the data I showed you on the last slide. And those patients who are in orange, who had the non-enhancing, you can at least see some shrinkages. Now, obviously, the caveat being a lot of them were not able to reach the partial response criteria. But most of this comes from oncology, where we are able to see those shrinkages. But as I outlined to you, that in the brain tumor world, we have not had the luxury of massive shrinkages. But one of the critical things in patients with brain tumors is, can we keep their disease stable and for a long period of time with a good quality of life? Because every time our patients and their brain tumors increase, it typically results in increased chances of neurological deficits. And quality of life is extremely important for our patients. So in these swimmer plot curves, you will see that especially in those patients who had the non-enhancing disease, patients were able to get the drug for 15 months, which is a good. Anytime we can keep our patients on drug in recurrent diseases, especially as these patients were with recurrent and progressive glioma, if we can get more than a year, we are happy to be there. So obviously in brain tumors, because we have this issue of blood-brain barrier, which limits the drug delivery to the brain, we are always very interested in these window of opportunity trials, which is basically giving the patient drug, taking them to surgery, and then seeing what is happening to the how much of the amount of the drug getting into the brain, and what's the pharmacodynamic impact, what it's doing on the pathway interaction and engagement. And so again, a complex trial slide, so I'll walk you through this. Basically, this was patients with diagnosis, a tumor recurrence, underwent randomization 2:2:1. They either received, there were no treatment, then patients got vorasidenib at 50 milligrams, ivosidenib at 500, and that was the cohort 1. And if there was evidence of target engagement, which there was, then they got either 1-to-1 randomization in cohort 2 to vorasidenib at 10 milligrams now, and ivosidenib was 250 but given twice daily. And then they would have on-treatment surgery, and post-treatment, if they got vorasidenib, they would continue vorasidenib, or they would continue ivosidenib till they were getting a benefit. And essentially, if they progressed, they would go off study. And there were a number of translational things that were built in terms of genomics, DNA sequencing, transcriptomics, RNA sequencing, 2-hydroxyglutarate, and number of IHCs. And what we found out was very interesting. Again, it's a busy slide, but let me just walk you through this. So if you focus on the left side of the slide, you can see the reference is the IDH wild type, and there is not a lot of 2-HG or hydroxyglutarate. But those patients who were untreated, you can see there's a higher amount of 2-HG. Basically, that means that the oncometabolite is there. And when you gave these patients vorasidenib, you can see there's a decrease in oncometabolite. So basically, there's a mechanistic way of knowing that there's a target engagement and the drug is actually working mechanistically. And there was a little bit more wider spread in ivosidenib, but there was a decrease clearly. On the right-hand side now, you can see there were 2 doses of vorasidenib given, 10 and 50. And clearly we saw that there were much higher response rates with the higher dose of vorasidenib. So number to remember is 50 milligrams once daily. And there you can see 40% response rate, which was pretty impressive compared to 10% with 10 milligrams. In the ivosidenib, though, again, the dose was same. It was 250 milligrams given twice daily, or 500 milligrams given once daily. And here you can see again, 500 milligrams once daily resulted in higher response rates of around 36% compared to 12%. Now, a number of these patients had been treated before. There was prior radiation in 30% of the patients and prior chemo in 40% of the patients. So this basically led to the fact that vorasidenib, a brain-penetrant IDH1/2 dual inhibitor, was then taken into a clinical trial called the Indigo trial, where this was patients who were greater than 12 or greater years, 12 or greater than 12 years of age, those who had IDH mutant grade 2, oligo or astro as per the WHO classification in 2016, had prior surgery only, had measurable non-enhancing disease, but most importantly, they were not in need of immediate chemo or radiation. So these were the patients who we were going to observe. and there were absence of high risk features, and I'll talk to you about that in a later slide. They were randomized 1:1 to vorasidenib, and the dose taken here was closer to that 50 milligram dose where we were actually seeing responses. So here the dose of 40 milligrams once daily was taken, and it was given continuously. And then patients were randomized 1:1 to receive placebo. But then what was it in patients was if they were found to that they had progressed, they were then allowed to cross over. The primary endpoint of the study was imaging-based progression-free survival by a blinded investigator radiology group. And then there was a key secondary endpoint, and that was the time to next intervention. Because remember, I told you these patients were not in need of any treatment. So the question was, can you delay that radiation or the next line of treatment? And there were a number of other endpoints in terms of PK, quality of life, growth rate, safety, response rates, overall survival, duration of response, and time to response. What were some of the exclusion criteria? Remember, the drug was not working very well in the enhancing disease, so grade 3s were excluded. If the patients had received any prior treatment other than surgery, they were excluded. So if they had received chemotherapy, radiations, vaccines, small molecule inhibitors, or other IDH inhibitors, they were excluded. And then the high risk was those patients who we felt could have needed treatment more urgently. That was defined as brainstem involvement, clinical, functional, or neurocognitive deficits due to the tumor, in the opinion of investigator, which would need treatment, or uncontrolled seizures. And so again, I went over the primary endpoint, I went over the secondary endpoint. There was 3 pre-specified analyses that were built in the study. One was the first interim analysis, which was for futility at 55 progression-free survival events that was looked at in January. Then there was a second interim analysis at 123 progression-free survival events that was basically also futility or superiority in September of 2022. And basically, this was able to showcase that. And then when the final analysis, 164 events had occurred, and no longer interim analysis was needed because there was a superiority outcome. Then let me just talk to you about the group. And most of these patients with low-grade gliomas, we know their median age is around 35 to 40 years, and this was no different. It was extremely well balanced in both the arms, and then the patients were most of them were either 18 to 40 years of less than 40 years of age, or between 40 to less than 65. We also dichotomized where the patients were receiving treatment in geographic areas, and you can see a predominance of the male compared to the female. And then we also looked at time from the initial diagnosis to randomization, and you can see very nice balance between the two arms. Again, similarly in the histology, very nicely balanced. Similarly in the 1p19q codeletion. And we also wanted to look at how large these tumors were. So again, you can see a very nice balance in most of these patients. Over 80% of those patients had longest diameter, which was more than 2 centimeters. And again, similarly, most of these patients had one surgery, but some patients, a quarter of them or so, had received 2 or greater surgeries. So this is the money slide. And again, this is the primary endpoint, progression-free survival for the blinded cohort. And here you can see the red curve, which is the vorasidenib arm, which is the experimental arm. And you could see a median progression-free survival of almost 28 months compared to 11 months with the placebo arm. And essentially, what I would like you to focus on is on the hazard ratio, which was 0.39. So when traditionally we've been given chemotherapies to our patients, like drugs like temozolomide, we were happy if we decreased that hazard by 30%, so like 0.7. And here you can see a very nice decrease in the hazard ratio with a highly statistical one-sided p-value of less than 0.001. And again, this is basically comparing the subgroups. So if you see things on the left side, that means it favors vorasidenib. If things are to the right side, they favor placebo. Busy slide, but basically all these subgroups that I talked to you about, there was a definite benefit in the favor of vorasidenib compared to the placebo arm. This was the key secondary endpoint, as I told you, which is the time to next intervention. And here again, you can see those patients who received the placebo, that was around 18 months. But those who actually were receiving vorasidenib, the median was not even reached 30 months out. But if you look at 18 months, there's a clear dichotomy, which kind of was preserved at 2 years as well. But the important thing here is the hazard ratio again. And you can see the hazard ratio is even more favorable for vorasidenib with 0.26, and again the one very highly significant one-sided p-value of less than 0.001. Again, one of the things that we have now in the last decade or so come to understand and appreciate in neuro-oncology is because we don't see that shrinkages which meet the endpoints of partial response or complete response. We want to look at the kinetics, that is how fast the tumor is growing, and can we use a drug and decrease that. So you can clearly see here those patients who had vorasidenib, they actually had a decrease 0.25 in the growth rate compared to placebo, where was still a growth rate increase of 13.9. So the delta is really 16.8, and the curves images are worth 1,000 words. You can see increases in the placebo arm and a very nice decrease in the vorasidenib arm. And this is the tumor growth rate again before and after starting drug. And clearly again, you can see if there's placebo, there's a continued increase, then there's a slight decrease, but then in the vorasidenib arm, you can clearly see the curve before and after. And if you look at the numbers in vorasidenib, pre-treatment 13.4% growth rate, but there's a negative. So that means there's a shrinkage post-treatment of 0.32. And in the placebo arm, you can clearly see there is a pre-treatment of 19.7, and still post-treatment, those patients still have a growth rate of 11.1%. Very important point when we treat our patients is when they're getting a drug, patients want to know how long will they get a benefit, but also a very important point is what's the safety of the drug or the quality of life. And here you can clearly see with vorasidenib that there was around a 23% grade 3 adverse events. Even in the placebo group, there were 13.5. The most common toxicity that actually we see in the clinic is increase in transaminases, which is around 10%. But I'm a medical oncologist and I've treated a lot of patients with cancer with a lot of targeted therapies. And I will say this is a very safe drug compared to a lot of other targeted therapies that we use in lung cancer, kidney cancer, or liver cancers, where the toxicity rates are much higher. Now, one of the other important things that we see in our patients is seizures, because patients with low-grade gliomas, highly infiltrating disease, can often have seizures. And the take-home message here is those patients who were on vorasidenib, there was a much lower number of seizure events on treatment, which you can see in the table was 1,541 compared to placebo, where it was almost 5,000. So almost, if you look at the rate, it's almost 3 times higher in the placebo patients. So not only were patients getting a clinical benefit in terms of the drug, the safety profile was acceptable, but also we had lower seizure rates, which is a very important quality of life for our patients. So this led to the approval of vorasidenib by FDA on August 6. Basically, FDA approved vorasidenib for adult and pediatric patients greater than 12 years of age with a grade 2 astrocytoma or oligodendroglioma with a susceptible IDH1 or 2 mutation after surgery, including biopsy, subtotal resection, or a glow cell resection. And vorasidenib has also now been approved in Australia, Canada, Israel, Switzerland, and the United Arab Emirates. The exciting part for me as a clinical investigator or a physician scientist is that this has really led to a whole activity in the space. And here you can see a number of trials where vorasidenib is now being combined with either peptide-based vaccines, temozolomide, or pembrolizumab. So there's a lot of interest in combining this with immune checkpoint inhibition, and I think that is going to be highly exciting data, and looking forward to those. And then there's a VIGO trial looking at now IDH1 to grade 2 and 3 gliomas after first-line chemoradiation, basically more as a maintenance setting. And then there are also a number of other IDH inhibitors which are being looked at. Ultasidenib, I talked to you about safusidenib and some of the data with that, IDH 305. So there is a number of opportunities for these patients to participate in clinical trials. And then these are other novel agents which are being evaluated, which is a whole spectrum. There is a lot of interest in looking at peptide-based vaccines. There are studies going on in the US. The Germans have done a lot of great work in the field. There is also an interest in these tumors because they almost have a BRCA nest to them. And so as a result, there is a lot of interest in looking at PARP inhibitors, either by itself or in combination with carboplatinum, or again with immune checkpoint inhibitors. There's also interest in looking at DMT1 inhibitors and a couple of trials with the immunotherapy. So in summary, what did we learn today? That there's a new treatment option for patients with IDH mutant gliomas. IDH inhibitors represent a novel class of oral targeted therapies which are designed to treat patients with gliomas with 1 to 2 IDH alterations. A phase 3 trial have clearly demonstrated statistically significant improvement in progression-free survival with vorasidenib compared to placebo in this patient population. And I was able to show you that there is when you look at the kinetics, there is an impact on tumor growth with IDH inhibitors, which can actually delay progression and slow the tumor growth rate, potentially offering clinical benefit beyond just delaying that. There was a seizure benefit, and the safety profile, as I showed you, is very favorable compared to a lot of other targeted therapies that we. But more importantly, there is an evolving landscape now with development of new IDH inhibitor, which represents a significant advancement in treatment of patients with IDH mutant gliomas, offering most importantly new hope for our patients with this challenging disease. And with this, it's my pleasure to pass on the podium to my dear colleague, Dr. Gonzalez Castro, who's going to talk to you about use of IDH inhibitors in the management of IDH mutant gliomas.
Welcome, everybody, and thank you, Dr. Alwalia, for doing a wonderful job of really outlining the knowledge that we have about IDH mutant gliomas and novel therapies that we have to treat these patients. We're going to try to translate all the information that was just shared with you in terms of how we can apply the knowledge that we have about IDH inhibitors and other therapies in the clinic. So let us start by looking at this case. And the message that I want to convey is that these are not trick questions. These are clinically relevant questions, situations that we might encounter. And the other important point is that there is not a single right answer. We are trying to understand how to best treat patients, and there's diversity in terms of opinions. And we hope that the answers that we get will reflect that. And as we review each case, I will share my thinking in terms of how to approach each of these situations. So case one is about a 23-year-old female with a right frontal astrocytoma, IDH1 mutant, WHO grade 2, after a subtotal resection and already after 12 months of observation without evidence of progression. What treatment strategy would you prioritize for this patient? A is continue observation. B, start IDH inhibitor treatment. C, start chemotherapy with temozolomide or PCD. D, refer for radiotherapy. E, refer for radiotherapy with a plan for adjuvant chemotherapy. And here we have the answers for this case. We see that 41% of these chose to continue observation, 48% recommended starting an IDH inhibitor, and a small percentage of these recommended chemotherapy, radiotherapy, or radiation and chemotherapy. And in order to discuss this case, I bring you to the age of this patient. This is a 23-year-old patient. And as always in oncology, when we treat patients, we are trying to maximize the lifespan of the patient. But at the same time, we need to take into account the health span, the duration of life that patients have, while at the same time being able to do all the activities that they'd like to do and perform to the best of their ability. So I'm a neurologist, and I have a bias towards the brain being the most interesting organ. And the brain is a dynamic organ. It's an organ that develops and continues to change throughout our life. And I would like to highlight two aspects in regard to two processes. One is the process of myelination, the process of strengthening connections between different areas of the brain or between the brain and other areas of the central nervous system. And as you can see here in this figure from a study, this is a process that takes place at different rates in different areas of the brain. And also it's a process that takes place throughout our lifespan. And as you can see, there's a peak period of myelination in the second, third, and early fourth decade of life. And this changes by brain area. But if we look at a patient that is in their early 20s, this is a patient that has not yet reached that peak. And through the introduction of therapies, we can disrupt this process and we can really change how the brain of a patient is developing. The other aspect that I want to highlight is the element of synaptic pruning. We have a lot of synapses that are formed early on in life that then become irrelevant for specific tasks. And the brain, as it matures, does away with some of them. So some areas of the cortex are thicker early in life, and then there's thinning, appropriate thinning that takes place as we really um, narrow the scope of different brain programs. And this is another process that can be affected by therapies that we use. And in particular, we have evidence that treatment with radiation in young patients can lead to changes in terms of brain development, cognitive outcomes, and quality of life. So Dr. Alwalia discussed the data from the Indigo trial, and he said, while showing the PFS data, this is the money slide. I think this is a very important figure showing the extension of progression-free survival in patients that were treated with the IDH inhibitor. But I think, to me, the secondary endpoint looking at time to next intervention is where the money is at. This is a treatment, IDH mutant inhibition is a treatment that is allowing us to really delay the introduction of therapies that, although have proven to have a benefit, are therapies that can really affect cognitive function and eventually quality of life. So in this particular case, I would favor answer B. And I have a patient that I base this case on who came to me in his early 20s with a tumor of these characteristics. And I decided to really defer treatment with radiation because I um, I noticed that this was a patient that was doing well, that was trying to accomplish certain goals in life, and I thought that the introduction of radiation at that time was not the best answer for the patient. So this patient has remained stable for 4.5 years, and he has had no evidence of disease progression, while at the same time he has continued developing normally. So let's go now to case 2. This is a case of a 31-year-old male with a left parietal oligodendroglioma, IDH1 mutant, 1p19q co-deleted, WHO grade 2. After a subtotal resection and some subtle increase in T2 flare signal at the borders of the resection cavity after 24 months of observation. What treatment strategy would you prioritize for this patient? A, continue observation. B, start IDH inhibitor therapy. C, start chemotherapy with temozolomide or PCV. D, refer for radiotherapy. Or E, refer for radiotherapy with a plan for adjuvant chemotherapy. So here we have a minority of participants that recommended continuing observation. 62% of participants recommended starting an IDH inhibitor. And then about between 8 and 15% recommended started chemotherapy, radiotherapy, or combination therapy of radiation and chemotherapy. I want to point out that the first case we discuss is within the label and within the design of the Indigo study. This case, where we have a patient that had a subtotal resection, had some residual T2 flare, and had some growth over 24 months, is also within the confines of the Indigo study. As in this study, there were patients that had been observed and had had progressive disease. And as I highlight there, approximately 83% of patients had more than 2 centimeters of disease, non-enhancing disease seen on T2 flare. And these patients, as we know, and as we reviewed earlier, also benefited from IDH inhibitor therapy. Let's review now the third case. This is a case of a 31-year-old female with a left temporal astrocytoma, IDH2 mutant, WHO grade 2, after a gross total resection. What treatment strategy would you prioritize for this patient? A, continue observation. B, start IDH inhibitor treatment. C, start chemotherapy with temozolomide or PCV. D, refer for radiotherapy. E, refer for radiotherapy with a plan for adjuvant chemotherapy. So in this case, 22% of participants recommended continuing observation, 57% recommended the IDH inhibitor, and between 5 and 8% recommended standard therapies. I would like to highlight a couple of things about this case. One is that this is a patient with an IDH2 mutation. And as Dr. Alwalia discussed, vorasidenib, the FDA-approved IDH1 and 2 inhibitor for glioma also has activity on IDH2 mutant tumors. The other thing that I want to bring your attention to is that this is a 31-year-old female. And one important aspect in terms of addressing quality of life with our RDH mutant patients is issues in regard to fertility and fertility preservation. So here, I think, as with all our patients, it's important to discuss, pregnancy and pregnancy considerations and the safety of any therapy. But this is a patient that, for example, if she didn't have children and had plans to start a family and have children, I think the observation option would be reasonable. If not, starting the IDH inhibitor is also an alternative. This is a patient also that had a gross total resection, in which case we are sometimes more inclined to do observation. But I note also that the approval label that was reviewed earlier also by Dr. Alwalia indicates that the drug is approved for patients with gross total resection. And as he alluded to, the concept of gross total resection in neuro-oncology is a challenging one. We know that these are infiltrating tumors, tumors that arise from at some point normal brain cells, and that we cannot really visualize and completely eradicate through surgery. So even in patients that have resection of all T2 flare disease, we know that there are tumor cells left behind, and we know that these cells are the ones that over time lead to radiographic and eventually clinical progression. So I think that if this patient is not having any plans to have children in the short term, initiation of the IDH inhibitor is reasonable. The data in terms of the impact of the IDH inhibitor on fertility is still emerging. My personal recommendation when I discuss with patients is that they're going to go on the IDH inhibitor. Sometimes it's important to consider fertility preservation efforts. So I have had patients that have frozen eggs, or if they're married, they have frozen embryos for future fertilization or implantation. And I think these are options that need to be discussed with these patients. We know that from preclinical studies, there is teratogenic potential of the use of the IDH inhibitor. So I think that strong contraception needs to be discussed with patients, both male and female patients that are on therapy. Let's review the fourth case now. This is a case of a 39-year-old male with a right parietal astrocytoma IDH1 mutant, WHO grade 3, after a gross total resection. tumor is without gadolinium enhancement on preoperative MRI, and grading is based on 4 mitosis per high power field. There is no evidence of homozygous or heterozygous CDKN2A deletion in molecular testing. What treatment strategy would you prioritize for this patient? A, continue observation. B, start IDH inhibitor treatment. C, start chemotherapy with temozolomide or PCV. D, refer for radiotherapy. E, refer for radiotherapy with time for adjuvant chemotherapy. So in this case, we have also a small minority that recommended observation. However, most people recommended therapy. And I think that there's a range between 10 and 20% of patients that are recommending the introduction of standard therapies. However, there's also a significant percentage, 45% of participants, that would consider an IDH inhibitor. Is an IDH inhibitor appropriate in this specific case? And there is a lot of debate and there's a lot of difficulty in terms of intermediate grading of IDH mutant glioma. We're starting to understand that IDH mutant glioma is, either a low-grade disease or a high-grade disease, and the grade 3 designation sometimes is not an appropriate one. I think of grade 3s as grade 3s that are really grade 2s and grade 3s that are really grade 4s. And this is some data from 10 years ago already highlighting that outcomes in IDH mutant grade 2 and grade 3 patients were essentially the same. So in this case, and this is also based on one of my patients, I recommend treatment with an IDH inhibitor. I know some caveats here, but these are some data that we published last year looking retrospectively at patients that were treated with ivosidenib, an IDH1 inhibitor that was approved for other indications but was available for use off-label, and that we have used to treat many patients. I have used to treat many patients. And here in this study, when we look back, we saw that the disease control rate was essentially the same for grade 2 and grade 3 patients. And there was not variation in terms of histology. So in patients that have IDH3 disease, and particularly those that don't have any evidence of CDKN2A deletion. This is a recent study we published too that helps stratify based on CDKN2A deletion status. We know that patients that have homozygous deletion are by definition grade 4 tumors, but we know that even patients that have just a single CDKN2A loss, heterozygous deletion, those patients tend to have a worse prognosis. So if there's no evidence of CDKN2A deletion, either homozygous or heterozygous, I consider an IDH inhibitor upfront. Let's review the last two cases. This is case 5, a 49-year-old female with a left temporal oligodendroglioma, IDH1 mutant, WHO grade 3, after a gross total resection, radiation, and 6 cycles of PCV with progressive T2 flare changes and new areas of nodular enhancement after 6 years of treatment. What treatment strategy would you prioritize for this patient? A, refer for a clinical trial. B, refer for re-resection. C, start IDH inhibitor treatment. D, re-challenge with PCV or offer temozolomide. E, refer for additional radiation. So here we see that a number of participants consider the clinical trial option, and this is important. We'll discuss that in a minute. There was also consideration of resection. This is also valid alternative. There were no votes for re-challenging with the standard chemotherapy options, and there were a small minority of patients, 12%, that recommended additional radiation. There was 50% of participants recommending IDH inhibitor treatment. And the point that I want to stress here in this vignette is the issue that what we observe in this patient's MRI at the time of radiographic progression is the presence of areas of nodular enhancement. And in the ivosidenib retrospective study that we looked, and also in a lot of prospective data with ivosidenib, vorasidenib, and other IDH inhibitors, we see that patients with enhancing disease don't really respond to single agent IDH inhibitor. And this is an evolving landscape, but in this particular case, I would not favor using monotherapy IDH inhibitor, and I would instead recommend clinical trial options if these are available. This is the number one recommendation on the National Comprehensive Cancer Network guidelines to refer patients at progression for clinical trials. And again, Dr. Alwalia reviewed this data, but this is from a recent review looking at all the studies in IDH inhibitors, and we see that for patients with enhancing tumors, the overall response rate is very low, if any, and there's shorter median progression-free survival. So the point here is that with enhancing disease, I don't think monotherapy with an IDH inhibitor is probably the best option for the patient. I highlight the clinical trial options, and this is one that I have enrolled patients in and makes sense from a scientific standpoint, is a combination of vorasidenib and pembrolizumab. In addition to the effect on epigenetic dysregulation of 2-hydroxyglutarate, we know that 2-hydroxyglutarate prevents T-cell infiltration into the tumor, so it has an immunosuppressive effect. And the use of IDH inhibitors can counteract that, and the combination of an immune checkpoint inhibitor makes a lot of sense. So this is an ongoing study. We'll see what the data from the study will show us, but I think that in this particular case of enhancing disease, we should consider other options or combination options rather than single agent IDH inhibitor. This is the last case now, and this is the case of a 41-year-old female with an enhancing right frontal astrocytoma, IDH1 mutant, WHO grade 4, after a gross total resection. Grading is based on high-grade histology and homozygous CDKN2A deletion on molecular testing. What treatment strategy would you prioritize for this patient? A, refer for a clinical trial. B, start IDH inhibitor therapy. C, refer for radiotherapy. D, refer for radiotherapy with concurrent and adjuvant temozolomide. And here are the answers. We have a 21% of participants trying to consider clinical trial options. I think that's very reasonable. 26% considering IDH inhibitor treatment, 11% recommending radiotherapy alone, but the vast majority are really opting for radiotherapy with concurrent and adjuvant temozolomide. So standard of care approach to high-grade glioma. This is an IDH mutant tumor that has, a number of worrisome characteristics. Not only has enhancement on MRI, it has high-grade histology, and it has evidence of homozygous CDKN2A deletion. That by itself, as we discussed, makes it a grade 4 tumor. So again, reiterating some of the points from the previous case, I think in this case, monotherapy IDH inhibitor is probably not the best alternative, and this is a situation we should consider bringing standard therapies early. In this retrospective study that I highlighted, we have some patients with grade 4 tumors. One of them treated with an IDH inhibitor as a second line has had some stable disease for a period of a year or so. But again, enhancing disease and grade 4 disease, we're not really hoping that this treatment, IDH inhibitor therapy by itself, will really lead to good disease control. And I've reviewed the data again on enhancing disease, where we have seen no responses or very limited responses. At least with ivosidenib and vorasidenib, there are other IDH inhibitors that are being studied, and these were studies that were discussed earlier on also by Dr. Alwalia, and there have been some responses there. So again, this is an evolving landscape, but the majority of the data tells us that single agent is probably not the way to go. And why is that? The reason, and this is from a recent study that we published, is that high-grade tumors are tumors that, in addition to the IDH mutation, have acquired other molecular alterations that drive the tumor independently of the mechanisms that are related to the IDH mutant enzyme. So they have acquired other oncogenes, or they have deleted other tumor suppressors that lead to IDH mutant independent mechanisms of tumor proliferation. So it's important to take that into account as well when trying to decide for therapy selection in this group. So with that, I would like to transition to a very important part of the program, which is when we're going to learn from one patient that has gone through the whole journey of diagnosis and treatment, and he will give us a very valuable perspective. So my pleasure to introduce Jeremy Piver here.
Hello, everyone. Hello. Hi. I know it's been a long day. So, my name's Jeremy Pivor, and I'm honored to speak with you all today. I'm here today because I've been living with a brain tumor for over 21 years, and I'd like to talk about my experience navigating my life with the glioma and also the different experiences I've had navigating different treatment settings. In 2004, after a seizure in my middle school gym, I was rushed to Boston Children's Hospital where they found this brain tumor. What we would learn was a grade 2 oligodendroglioma, IDH2 not 1 mutated, MGMT unmethylated, located in my left sensory motor cortex. Originally, the surgeons didn't want to operate due to its sensitive location, but after several more seizures, we found a surgeon who would partner with us. This is me with Mr. Frog, showing my accomplishment of lifting my arm after being fully paralyzed on my right side. Doctors expected the paralysis to last for at least 3 months, if not longer, but after just 4 days, to everyone's surprise, I was able to slightly move my arm and leg. I then spent over 2 months in the hospital doing intensive PT and OT. I lost some movement, particularly below my right ankle, but this experience gave me a new outlook on life. I was given a second chance. It took a lot of time and rehab, but over the next decade, I recovered enough to play varsity tennis, go to college where I became an EMT, travel abroad to Madagascar, sail the high seas, and eventually, after college, receive a national scholarship to do ocean conservation in Indonesia, where I lived and worked. I was living my dream, diving the most beautiful reefs and exploring places I had never imagined. But in 2014, I had a seizure in a hostel in Singapore. I went home for Thanksgiving and was diagnosed with a recurrence. My life in Indonesia, my dreams, my sense of being a normal young adult disappeared. Due to the tumor's location, surgery wasn't an option, so I underwent the standard of care at that time, temozolomide and proton radiation. Out of necessity, I started to learn how to better advocate for myself, but also others in the brain tumor and young adult cancer community. I then made the crazy decision to apply to medical school, where I was accepted into a joint medical program at UC Berkeley and UCSF. In 2018, 9 months into medical school, I had another recurrence, just 4 years since my last one. This time, surgery was an option. The next by the book step would be standard chemotherapy. But due to my molecular makeup, that may have made standard treatments less effective. And to save the chemotherapy for down the road, we opted for an experimental approach, an axitinib. Unfortunately, there was enhancement growth, and my tumor had evolved to a grade 3 anaplastic oligodendroglioma, still IDH2 mutated, MGMT unmethylated, but with even more mutations. So we pivoted to immunotherapy combined with radiation to see if we could utilize the abscopal effect. I was made very aware about the experimental nature of our approaches, but I also knew that my tumor, given its life history and characteristics, was an N of 1. I had to trust from the limited data available, sometimes from bench studies, that this could work. I stayed on immunotherapy for nearly 4 years, sometimes in San Francisco and sometimes in Boston, when I continued to live my life, finished my master's portion of my education, and got a job back home at Harvard. But as the pattern went, 4 years since my last surgery, I had another recurrence. I underwent another surgery and was out of the hospital, to my disbelief, in less than 48 hours. But I was starting to reach the end of the road in adjuvant therapies. I had to decide, do I wait or do I use one of my last standard treatments, chemotherapy? I decided to wait with the hope that I would create more time for another option to come along. And 9 months later, I had the opportunity to start vorasidenib. But a few months after starting vorasidenib, this enhancement spot appeared. It remained stable in 2024, but recently in 2025, it grew. While the vorasidenib was controlling the non-enhancement areas of my tumor, it was not slowing down enough the growth of the enhancement area. So I decided to stop vorasidenib for now and use the standard of care chemotherapy I had been keeping in my back pocket, lomustine and procarbazine. 21 years of living with this brain tumor has been a lot to navigate. When I was asked to talk with you not only about my journey, but experiences across treatment settings, I decided to choose the 3 setting changes that impacted me the most. The first was moving from pediatric to adult oncology. As a young adult, I went from being the oldest in the kids' waiting room to the youngest in the adult areas, always sticking out. Always getting mistaken for the caregiver of my mom, catching glances questioning, why is this healthy man here? It increased feelings of isolation during a time that was already so lonely. Beyond the waiting rooms, moving from pediatrics to the adult world was challenging. As a child at the Jimmy Fund, I received whole person care usually all during the same appointment. When I had my first recurrence, I moved to the adult side under the amazing care of Patrick Wen. But the overall way my care was coordinated drastically shifted. Instead of feeling like an individual, I became my medical wristband. I went from knowing what to expect and the clinic putting everything together for me to having to be my own care coordinator. In the adult world, it felt like all the different specialties were disconnected. With each clinician, I became responsible for getting referrals, scheduling appointments, handling insurance, going to appointments at uncoordinated times, providing updated history and meds to every person, and most of all, trying to make sure everyone was on the same page. Additionally, the adult cancer setting didn't seem constructed for the special needs of a young adult, particularly the psychosocial needs. My friend, who is also living with advanced cancer, put it best when I asked her about care coordination. She said, well, I was going to say, I don't think I have care coordination. I think I do it myself. And honestly, most of the time, that's how I feel too. Why is this so important? Because without it, the people filling or attempting to fill the gaps are the patients and caregivers, my mom and I. And this turns into a full time job that is stressful, exhausting, and ends up costing me a lot of money. Beyond all the symptoms I get from the years of surgeries, past treatments, and current treatments, trying to fill the gaps of care coordination can often push me to burnout. For me, as a brain tumor patient, that can look like increased seizures, headaches, and needing to sleep a lot more. And all of that interferes with my job and personal life. Ultimately, it comes down to moving away from the reductionist approach where everyone has their silos and moving beyond thinking that a referral equates to care coordination. And it means recognizing the importance of and need for implementing whole person multidisciplinary care. Imagine if all providers were connected in a multidisciplinary team and based on what was impacting me at a certain time, I would be able to see the relevant people all in one visit. For example, when I was on one of my experimental treatments, I started having unexplained episodes where I was almost passing out. I had appointments with my PCP to get tests done, my oncologist to discuss my treatment, the neurologist to check if the episodes were seizure related, cardiologist to check if they were heart related, and therapist because of the stress of all this. But what if it was like the Jimmy Fund Clinic and I could go in with an itinerary to see all those specialists in a single day after they had coordinated with one another? If it can be done in pediatrics, can it not be done with adults too? The second treatment setting change I want to talk about is moving from treatment to survivorship, which for me has happened 4 times. People often think the struggle of cancer is done after treatment, but survivorship is like a no man's land where there's a sense of feeling lost with little direction. There are few survivorship programs dedicated to young adults. Most young adults are guided either to pediatric or adult programs that don't address unique needs that young adults face. While it isn't a complete list, young adults during, but particularly after treatment, face unique physical, psychosocial, and logistical needs. I face all of these in my own journey, but I want to highlight a couple that aren't commonly discussed. The first is the transition from surgery to outpatient rehabilitation. During my past 4 brain surgeries, the time I have been in the hospital has decreased, which is excellent. However, every time, especially because my tumor being in the motor cortex, it is strongly recommended to get into rehab as soon as possible. Unfortunately, the reality is that most physical therapists who specialize in neuro are booked weeks, if not months, in advance. I've been in the hospital bed just 24 hours after surgery, my mom and I on my phone, trying to call different places to get me in for an appointment. And that shouldn't be the case. On top of all the time delay issues, there's also a lack of rehabilitation. Forgot to do that. A lack of rehabilitation, providers specialize in cancer, which places me, the patient, too often in the educator role. Another significant gap of care, particularly for young adults, are issues related to sex, intimacy, dating, etc. In my experience, providers have been very comfortable bringing up fertility preservation, but any other questions related to sexual health, I have had to ask or research on my own. Additionally, as a gay man, most information available focuses on a heterosexual cancer patient. I have talked with many young adults who say that they have never brought up the subject because the door for these types of conversations have never felt open to them. Those are just two of many examples. We must work together to get rid of this no man's land of young adult cancer survivorship by creating more avenues of communication, resources, and guideposts that specifically address our unique needs. And as we do this, recognizing that the needs for survivorship change as we get older, from 12, 23, to 27 to 31 years old. Now, the final treatment setting change I want to discuss is the transition from having versus living with cancer. In 2014, I knew I would always live with cancer. Due to advances in treatment and technology, some cancers are increasingly being seen as a chronic condition. Survivorship resources are often tailored to individuals who go around the cycle of treatment, survivorship, recurrence once, maybe twice. But what about people who are repeating the cycle 4, 5, or even more times? We need to focus on long term management and quality of life for these individuals. And this is where palliative care needs to be integrated. Over my 21 years of living with a brain tumor, my bridge I've been sitting on has started to crumble. Whether that is due to physical stressors like fatigue, emotional impacts like contemplating my mortality, or logistical day to day challenges such as making sure I can sustain my job so I have medical insurance. The cracks continue to increase over time. Palliative care acts as a support beam to hold me, the cancer patient, but also the care partner up. And importantly, we need to communicate better to patients that palliative care does not equate to hospice or end of life care. I was never referred to palliative care, so I learned to build my own support brackets primarily by figuring out what I valued most in life: my family, my partner, who's sitting here today. It's our anniversary today. My passions. Oh, thank you. And giving back in whatever way I can. These values have sustained me as I navigate my journey with brain cancer. But I have only been able to navigate all of this because I had the incredible support. First and foremost, my mom, who taught me to be an advocate, Dr. Bush, my PCP, and Dr. Wen, my oncologist, who treated me like a partner, and Dana-Farber's young adult program, including its former director, Karen Fasciano, and its current director, Christina Pozo-Caterman. I'm also lucky that I have not had to face too many barriers in my journey. Many patients face challenges with insurance, transportation, finances, food access, mental health support, community support, and more. And I say all of this not only to name my privilege, but also point out that if I am facing difficulties in my cancer journey, it is certain that those who are not as lucky as me are having much harder time. For this talk, I asked my mom, what would you say to a room full of care providers in oncology about the difficulties patients encounter during the transition between treatment settings? And she said, you can't just look at treating the cancer. You need to help the individual deal with the next steps in their lives with their diagnosis. Whether it's middle school, high school, college, or as an adult, there needs to be additional support to help that patient navigate all the psychosocial elements in their lives. What do you do with someone who just says, I'm done, when it all becomes just too much to handle? How do you help them walk the path forward? And I responded, and also, how do you help the caregiver during these periods too? The healthcare professional needs to communicate with the patient and caregiver more about these topics. They need to educate the patient because patients don't know what they don't know. They learn from having to experience it all over time, which shouldn't be the case. Providers shouldn't wait for patients to ask about these issues. There should be support systems from the beginning. And to that, she said, I imagine your cancer journey as a river with different tributaries. And when there's a new recurrence of bend in the river, new tributaries are created. You've changed from ocean biology to medicine to being forced to use your talents in other ways. You've had to maneuver this river most of your life, and you could have given up so many times. And I replied to her, but I had the support I needed. As you have heard, there's so much more to my life with the glioma that is not depicted in my medical history. My mom and I were lucky to have support we needed to make it to 21 years and hopefully much more. Together, we need to work to fill the gaps for all patients and make navigating life with cancer, transitioning between those treatment settings, easier. Thank you.
Thank you very much, Jeremy. Thanks to all the speakers. I would like to start, yeah, um, to highlight what we want to, what the aim of the discussion is. We want to talk about what multidisciplinary tumor boards are and how important they are for clinical decision making. Speak about real-world experiences in diverse care settings and the challenges and unmet needs in optimizing patient care. And I would like to ask you, Nick, to maybe comment on first who are the important people in the tumor board and how important is it to you for clinical decision making?
Tumor boards are essential. We all of medicine is a team sport, but I think in neuro-oncology this is particularly relevant. As Jeremy beautifully highlighted, we work together with a number of colleagues. Many of them are represented here. I didn't see anyone from neurosurgery, but as we know, um, without tissue, we don't have a diagnosis, and a good resection is the first and important step in the management of patients with IDH mutant glioma. So I think that tumor boards are critical to understand exactly, who the patient is. Our tumor boards are attended by mid-level providers and social work staff that can often provide that perspective. What is the diagnosis, the critical input from pathology? And we are at a stage where we can really characterize tumors in depth at a molecular level. So understanding the patient, understanding the diagnosis, and then understanding the treatment options and discussing in a collegial way, how we can best sequence the tools that we have for the treatment of the patient. So um, I think that in neuro-oncology, tumor boards are essential to providing optimal care.
Thank you, Jeremy. What is your perception of the tumor board? How important do you think it is? Or is there anything that you would like your physician team to change about the tumor board?
I think it's essential, and I think you can tell from my talk, I'm all for multidisciplinary care. Um, I think it's a little bit of a shroud between the patient and what happens at the tumor board. I mean, now with more notes being available, you can kind of see what conversations happen. And I'm not advocating for patients to be part of the tumor board at all, but um, to educate the patient almost a little bit more about what actually goes on during those types of tumor boards and who is there, so they're not thinking, oh, is my physician maybe missing something else, and do I need to get a second opinion over here? I think there's a bit of patient education that can happen with that, but it's necessary. And if those specialties are not talking with each other already in a board setting, they need to be connecting.
Would you actively ask your case at a recurrence, for example, to be discussed in a tumor board or discussed again if you're not happy with, for example, the outcome?
Definitely. And I like have full trust in Dr. Wen. Him and I have established over a decade long relationship with each other and work with each other as partners. But when there's a new obstacle that comes out up, I would love as many eyes on it as possible from different viewpoints of different specialties. And I'm also, I'm a proponent for other patients get second opinions too. And I know patients are afraid to do those types of things because they think they might be insulting their current physician. But even getting opinions from other physicians and other locations join that tumor board discussion is important.
Okay, thank you. Manmeet, you have shown us a lot of data that have accumulated recently on IDH inhibitors. What, in your view, are the main data gaps? What are the white spots on the map that we have to fill?
So first of all, I will say, we're excited by the data we have generated because it has given us, potential opportunity to do more. And I think Nick outlined really with 6 very eloquent cases of some of the challenges that we are facing, right? So we know what's the label. So clearly, grade 3, grade 4 tumors now, your patients with those are asking, can you treat me? And then, as in neuro-oncology, we've done a lot of times we do off-label treatment. But it's the important thing is of telling the patient, and Nick outlined a couple of real world evidences they've been able to generate, looking at not only vorasidenib but ivosidenib and some of the other inhibitors that we've used in clinical trials. So I think grade 3 clearly, grade 4, and there are a number of efforts going on the Vigor trial, as I outlined, I think clearly. Big question is obviously this was patients who were being observed, and question is like, if there are some changes now, patients say, I want the targeted drug, right? I don't want to get undergo radiation chemo. And that becomes a challenge because we have data, obviously level 1 evidence, if patients need treatment like tomorrow, that it's radiation and chemo. But the question is, so that's another thing. Then also there's a question of maintenance, which needs to be answered. So there's several things. And then one of the other aspect which we need to cover is not everyone gets benefit. So the question is, people who are failing, what's driving that mechanism of resistance? Can we combine then vorasidenib with other inhibitors, immune checkpoint blockade? I think that's a very exciting trial, clearly, because of the clearance of 2HG with this, then mechanistically decreasing the immunosuppressive environment that the 2-hydroxyglutarate creates, really. And then maybe that will increase the immune checkpoint blockade, because obviously, we've seen a number of other cancers where immune checkpoint blockade is really transformed. And there's some brackiness here. So I think if we can get that, I'm very highly excited about that. Then other is obviously combining similarly peptide, vaccines, which obviously work has been done a lot in Germany, your part of the world. So I think there are several questions which still need to be addressed. But I think the good part is now we've seen success and we know we can add to that. So it's like I always see oncology as building blocks. So you have a foundation. Question is, can you expand it more, extrapolate, and then build with others? Because a lot of other cancers, we really have people living long term. And I will take this classic example of lung cancer, where I had started treating, these patients lived only 12 months. And now they're living 3-4 years out, right? So you've got a number of targeted drugs, but you also have immune checkpoint inhibitors combined with chemotherapy, and hopefully this will lead to those exciting trials which will fill in those gaps.
Okay, thank you. You have mentioned the Vigor trial a couple of times. Maybe to explain what that is.
So essentially, essentially what we are looking at, so this study, which was the Indigo trial, looked at those patients who basically were being observed. And we had a number of those patients. In fact, when the drug actually got approved, and a couple of patients who we had decided to observe, and then, and I would go back to the importance of tumor board, by the way. I mean, I think tumor boards are remarkably important in neuro-oncology because sometimes we do not have the evidence to treat every possible case. So you need that. And when I talk to my patients, actually, I tell them that although I am presenting the case on your behalf, I've got 3 or four other colleagues like me who are medical or neuro-oncologists. They are brainstorming. I've got neurosurgeons who operate on these patients every single day of the week, along with radiation oncologists. We also need to highlight a neuropathologist and neuroradiologist because we have a lot of challenges with the imaging. Actually, a lot of times we are not sure whether there are some changes. It's radiation related if the patients have received radiation, or is it tumor progression. So just going back to that point, but the Vigo trial now obviously is like, can you use maintenance, what is it name, after chemoradiation, and see if basically, because we know when we give chemoradiation the patients get benefit definitely. So chemoradiation is better than radiation. That's a take home point. Clearly the RTOG 9Q82 showed that. One question that was actually asked, and Dr. Gonzalez Castro had answered that chemo alone approach, and some people pick that. Actually, there is data from UCSF that if you give temozolomide alone, the overall survival was around 10 years. So we clearly have data that you can do 14 years. So typically, there are changes when you use, alkylating agents in terms of hypermutation that sets in, and other mechanism of resistance. So I would say if you need definitive treatment, as much as we don't like radiation, we, at least at our center, will give radiation chemo for those patients, because chemo alone has not had the progression-free survival or overall survival, although not directly comparable. So here the question is, even when we use radiation and chemo, patients will have progression-free survival that is more than radiation alone, but then resistance checks in, and then the tumor grows. And in brain tumors, we don't want people to have progression, as I outlined in my talk, because that may lead to a new deficit. And obviously, Jeremy, amazing story, and thank you for sharing that with us. It gives people hope, but it also shows the involvement of patient and their family in their care. So here it's the question is, can you add therapy then, and can you then increase the progression-free survival even more?
Thank you. Speaking of imaging, you mentioned imaging. Nick, how often do you scan patients, and how do you decide on the interval?
This is an important question because we are in an age that we can really leverage imaging, and in some cases, some advanced imaging techniques to really know where the tumor is at. And initially, you have to get to know the patient first of all, and then get to know the tumor. So I favor initial close radiographic and clinical follow-up. So I'm seeing my patients every 8 weeks, and I'm getting MRIs every 8 weeks. As you start to learn more about the patient and the tumor, sometimes I extend the radiographic interval to 3 months, 4 months, sometimes 6 months. I don't like to go beyond that interval. These are patients that we are following for many years, sometimes decades. Uh, but if there are any changes in the tumor, even if patients are clinically stable, I want to know. And I alluded to some advanced imaging techniques. There is the possibility of detecting levels of the oncometabolite 2-hydroxyglutarate through MR spectroscopy. And this is a technique that we have at our center and is available at other centers. So sometimes when you see areas of T2 flare changes, you could try, if they're large enough, you could try to use MR spectroscopy to really detect if those changes are due to treatment-related effects or due to disease progression. Our European colleagues also in Germany are very active using PET, amino acid PETs, to try to also characterize true progression from pseudo progression. So I think it's an exciting time. But bottom line, get to know the patient, get to know the tumor, and I tend to err on the side of imaging frequently, particularly early on.
Okay, thank you. Jeremy, you've heard us discuss a lot of data. Is there any research question that you would like us to work on?
Huh. I think the research being done in the combination of vorasidenib with other treatments is really interesting. So as I was saying, I'm currently on CCNU and procarbazine, and when we hopefully get to 6 cycles and finish that, I'll be going likely back on vorasidenib because it was doing a good job in controlling the non-enhancing area. But I'll probably still have a bit of enhancement there. Although with MRIs just recently, even with 2 cycles, it's been shrinking a little bit, which has been good. And so what are those combination therapies that can, you know, help address the enhancing part while holding steady the non-enhancing area? That's what I'm excited about.
Okay. What's your best hope to answer that?
What I would say is obviously, the essence is whenever you make a decision in a particularly case of a patient, so you always want to have patients buy-in, because I think patients are increasingly their own advocates. The people's ability to find data online has increased tremendously as compared to 2 decades back, so it's always nice to get patients input. But I think, as I talked in my slides before, I think it's just so exhilarating to see dozens of trials now coming through the pipe, not only one IDH inhibitor, but multiple IDH inhibitors, combinatorial trials, because again, I think really it's building block strategy again. So we will have to figure out biomarkers of response, the people who will do well, then biomarkers of resistance, and then design the next cadre of trials. How, because again, oncology is all about a play of what benefit you're going to go at and what cost are you going to pay. So if someone can get really good outcome with a single drug, you don't want to maybe give them a combo. But if you know that looking at the biomarkers, that you have data that they're not going to get benefit with a single agent, then maybe combinatorial effort is the way to go there. Because again, you want people to live as long as possible, and the dogma is with a good quality of life. So that's what we do. And whenever I make a decision, I always take the patient as a active partner in that decision making, or their family members, depending on their input.
Thanks. I will ask one last question to Nick before I will ask you, Manmeet, to do the concluding remarks. When is the optimal time to initiate IDH inhibition after gross total resection? Difficult one.
Yeah, I alluded to this earlier in one of the cases. As I discussed, there is no true gross total resection. We know that there are tumor cells that are left behind. Despite of how the outcome of operations sometimes is discussed by neurosurgery colleagues, we can never get it all out. So this therapy really um, prevents all the epigenetic changes and also all the effects on the anti-tumor, the innate anti-tumor activity that we have. So I usually implemented shortly after patients have gross total resection. This is the case of some of the patients I discussed, including my patient that has a grade 3 tumor with no worrisome molecular features and has been on treatment for over 4 years with stable disease. I started him shortly after gross total resection.
Thank you for the discussion. Thanks to our speakers for their contribution. Special thanks to Jeremy. And I would like to ask you, Manmeet, to conclude the session.
So again, I would echo what Dr. Prusa said. Thanks for Jeremy Power for really sharing your inspirational journey, and glad to see you're doing well and wishing you the best for the future. Happy anniversary again. And then to obviously Dr. Castro for really sharing some excellent cases, which not only addressed the FDA approval of the drug vorasidenib, but also the gaps and how to tackle the data that is there now while we work together and generate future data. What I will say is it's really exhilarating to see the finally us living the premise of precision oncology, because we often use that term. But what that means is finding the right target in the patient to find the right drug for the right patient at the right time. We are excited, highly excited about the pipeline of new drugs that are being developed, new combinations that are being developed so that we can serve our patients importantly. Again, I will basically make a pitch. If you don't have good options, clinical trials, as Dr. Gonzalez Castro outlined, remains the top recommendation. Always seek for a complex cancer, we always it takes a village to take care of these patients. So get your treatment at a place where people do this on daily basis. The surgeons who operate on a daily basis, you recovered remarkably quickly after your surgery, even beyond what people thought you would do. And it's so exhilarating to see that. And overall, you just are as strong as your team. So if you're working in a multidisciplinary manner, you're able to take better care of your patients. Still, there are gaps that need to be filled in. We need to do better with our patient navigation, patient expectations, and filling in them what is going on. It was great to have you.